We're going to cover their etiology, clinical features, diagnosis, and treatment protocols. Our lineup today: Hydatid disease, leprosy, poliomyelitis, and finally, tropical chronic pancreatitis. All right, round one. We are kicking things off with Hydatid disease, which is caused by Echinococcus granulosus. So this tapeworm is heavily clustered in rural sheep farming and tropical regions. Let's actually trace its biological pathway, because it's wild. It all starts with oral contamination from infected dogs, which eventually leads to these complex three-layered cysts forming right inside human organs. The dog acts as the definitive host, harboring the adult worm and passing eggs in its feces. Then, humans, along with sheep and cattle, act as intermediate hosts after accidentally ingesting these eggs. Once inside us, the parasite develops into a cyst that has three very distinct architectural layers. The outermost is the pericyst, which is basically a fibrotic layer made of compressed host tissue. Inside that, you've got the ectocyst, a kind of intermediate hyaline membrane. And finally, the innermost layer is the endocyst. This is a germinal membrane that actively generates viable fluid and these things called protoscolices. And get this, it can even separate to produce internal daughter cysts. To figure out how to treat this, the WHO Informal Working Group on Echinococcus categorizes these cysts by whether they're active or inactive. This directly dictates the clinical management, and it's all done using standardized ultrasound imaging. For instance, stages CE1 and CE2, those are active. CE1 shows a uniformly anechoic cyst with fine internal echoes. Clinicians call this hydatid sand. CE2 shows internal septations, kind of looking like a honeycomb or a rosette. Then we move into transitional stages like CE3, where the cyst actually starts degenerating because the host's immune system is fighting back. Finally, we hit the inactive stages, CE4 and CE5. A CE4 cyst looks like a complex bag of wool, and by CE5, the whole thing is completely degenerated and calcified. Now, while ultrasound is amazing for looking at the liver, we actually rely on chest radiography for pulmonary cysts. And here is a fascinating detail. If a pulmonary cyst suddenly ruptures, you'll look for this pathognomonic water lily sign on a plain chest X-ray or CT scan. Before it ruptures, you might catch a meniscus sign where air gets trapped between the cyst layers. But once it fully pops, that innermost germinal layer, the endocyst, collapses and literally floats on top of the residual fluid. It looks exactly like a water lily pad floating on a pond. These cysts usually grow super slowly and just cause localized pressure. But a sudden rupture introduces highly antigenic fluid straight into the system, and that can trigger sudden anaphylactic shock. The liver is the most common spot for these cysts, where progressive stretching of Glisson's capsule causes a really dull right upper quadrant pain. The lungs are the second most common site, leading to dyspnea and coughing. If daughter cysts rupture directly into the biliary tree, it presents with obstructive jaundice and ascending cholangitis. And like I mentioned, trauma can trigger a massive cyst rupture, turning a slow-growing problem into an acute emergency of severe anaphylactic shock. So how do we treat the active cysts? Surgeons use a minimally invasive approach called the PAIR protocol. That stands for puncture, aspiration, injection of a scolicidal agent, like hypertonic saline or ethanol, and finally, reaspiration. It's incredibly effective. However, there is a massive catch. If imaging, like an MRCP, shows that the cyst is communicating with the bile ducts, injecting these harsh scolicidal agents is strictly contraindicated. Why? Because doing so can induce severe, irreversible sclerosing cholangitis. Definitely something to avoid. Okay, moving right along to our second clinical profile, leprosy, which is also known as Hansen's disease, caused by Mycobacterium leprae. This particular acid-fast bacillus is really interesting because it selectively targets the cooler zones of the human body. We're talking about the nasal mucosa, skin, earlobes, and peripheral nerve trunks. Transmission happens through close, prolonged contact by inhaling nasal secretions, often starting in childhood and gestating over a really long incubation period. When we look at the global burden, the sheer scale is staggering. India alone accounts for 78% of all leprosy cases worldwide. It's a disease highly concentrated in the tropics, with India, Brazil, Nepal, Mozambique, Angola, and Myanmar accounting for 91% of all global cases. Now, the way leprosy presents clinically is entirely dictated by the patient's immune system. A robust response localizes the disease, while a depleted response allows the bacillus to spread everywhere. In tuberculoid leprosy, the host's cell-mediated immune response is actually pretty strong. You'll see scant bacilli, numerous lymphocytes, and localized tissue damage. This is often asymmetrical, featuring thickened peripheral nerves and really well-defined skin lesions.
On the flip side, we have lepromatous leprosy, which happens when the host's immune response is profoundly depleted. The bacillus disseminate widely and symmetrically all over the body, accompanied by a ton of macrophages but very few lymphocytes. And of course, there's a dimorphous or borderline spectrum that sits right in between these two extremes. That specific immunological failure in lepromatous leprosy leads to some severe cutaneous manifestations. One of the most classic is leonine facies, which literally means a lion-like face. The extensive, symmetrical disease causes pale macules to merge into diffuse plaques and nodules. This acute nodularity drastically alters the structural shape of the face, and the chronic skin wrinkling that follows creates a prematurely aged appearance.
The targeted destruction of peripheral nerves yields some very specific and devastating structural deformities. Facially, the invasion destroys the nasal septum, completely collapsing the nasal bridge. Damage to the facial nerve paralyzes the orbicularis oculi muscle, which prevents complete eye closure, a condition called lagophthalmos, and that can ultimately lead to permanent blindness. Moving to the upper limbs, ulnar and median nerve damage creates a bilateral claw hand with dense anesthesia. This makes the patient highly susceptible to mechanical and severe thermal injuries. In the lower limbs, damage to the lateral popliteal nerve causes complete foot drop, while anesthesia in the foot leads to chronic trophic ulcerations on the soles, and eventually autoamputation of the toes. Beating this requires a true multidisciplinary approach. While it was historically treated with chalmugra oil, modern medicine now relies on the WHO's 12-month multi-drug therapy. That's a combo of dapsone, rifampicin, and clofazimine. Surgically, the goal is to restore function. Surgeons perform highly specialized tendon transfers, like recreating lumbrical muscle function in the hand so the patient can grip again, and posterior tibialis tendon transfers to fix that foot drop. Those trophic ulcers, they're managed with surgical debridement and total contact plaster casts. But just as crucially, aggressive public education is required. We have to eliminate the derogatory term leper and stop social ostracization so that people feel safe coming forward for early treatment. Next up, we are examining poliomyelitis, an incredibly targeted viral infection. Polio is an enterovirus that selectively destroys the anterior horn cells of the spinal cord, and that causes pure lower motor neuron paralysis. It's contracted via inhalation or ingestion, and primarily targets kids in specific tropical regions, hitting the lower limbs about twice as often as the upper limbs. Now, if a patient presents with an acute fever and muscle weakness, how do you differentiate polio from Guillain-Barré syndrome? Well, the absolute absence of sensory signs confirms the polio diagnosis. Both cause weakness, sure, but Guillain-Barré actively features sensory symptoms, because the poliovirus strictly targets those anterior horn cells, which are entirely motor neurons. Sensory function remains completely 100% intact. Now, here's something that might surprise you. Despite the terrifying reputation of the virus, paralytic manifestations actually occur in only a tiny fraction of infected patients, about 1 to 2%. The clinical spectrum really ranges from just a transient, mild fever and headache all the way up to severe, fatal bulbar paralysis. But the vast majority of cases never reach that paralytic stage. So let's look at how this pathophysiology actually dictates our surgical strategy. Surgeons must wait up to 2 years before operating on a polio patient. They have to take extreme care not to disrupt the highly effective compensatory trick movements that these patients naturally develop over time. Surgery is strictly confined to the chronic phase. Why? Because muscle function can naturally keep recovering for up to 24 months after the acute illness, making early intervention totally contraindicated. Once the patient has stabilized, orthopedic surgeons can perform highly targeted reconstructive tendon transfers and surgical arthrodesis, meticulously preserving those unique adapted movements. All right, let's move to our fourth and final clinical profile for today, tropical chronic pancreatitis. And what really stands out here is its strictly non-alcoholic etiology. The dietary pathogenesis of this condition is absolutely fascinating. This disease primarily affects severely emaciated patients under 40 in southern India, and notably, alcohol is not a factor here. Instead, a simple staple diet of cassava, combined with specific amino acid malnutrition, triggers a devastating cascade of chronic cyanogen toxicity that essentially destroys the pancreas. Cassava, or tapioca, is a cheap root vegetable that contains cyanogenic derivatives. Normally, a healthy liver detoxifies these compounds using sulfur-containing amino acids. However, this severely malnourished population completely lacks those essential amino acids.
Consequently, the liver fails to clear the toxins, resulting in chronic cyanogen toxicity that induces intense interlobular and periductal fibrosis deep within the pancreas. This profound parenchymal damage leads to both exocrine failure and a very specific form of endocrine failure. Clinically, you'll see patients presenting with severe thirst and polyuria. The intense destruction of the pancreatic islets just brings insulin production to a grinding halt. This results in what we call fibrocalculous pancreatic diabetes, which is effectively a secondary form of type 1 diabetes mellitus.
Now, diagnostically, there's a real twist. Surprisingly, serum amylase usually remains completely normal. But if you take an abdominal X-ray, it will reveal pathognomonic dense calcific stones tracking right along the dilated main pancreatic duct. Patients usually present with severe abdominal pain and gross exocrine insufficiency that causes chronic steatorrhea. Under a microscope, the pancreas is firm, shrunken, and heavily nodular. Inside the ducts, massive calcium carbonate stones form. Sometimes they even branch out like staghorn stones. And it is absolutely critical to note that these patients carry a significantly elevated risk of later developing pancreatic cancer.
So how do we treat it? First-line management is always aggressive medical and nutritional support. The medical side focuses heavily on replacing pancreatic enzymes to stop the steatorrhea, managing that fibrocalculous pancreatic diabetes with insulin, and using a standard analgesic ladder to control the intense pain. But when the pain becomes absolutely intractable, usually because those massive stones are obstructing the main duct, surgeons have to step in. Because these patients are so young, major resections are truly a last resort. Instead, they perform a longitudinal decompression. Basically, it's a side-to-side pancreaticojejunostomy connected to a Roux-en-Y loop to drain the duct and finally relieve that immense pressure.
From mapping out the active stages of a hydatid cyst to waiting for the exact right timing for tendon transfers in polio, the intricate connections between a disease's pathology and its management are just vast. We've seen the profound structural impact of these diseases today. So I'll leave you with this. As medical management continues to evolve, how will new surgical innovations and focused public education reshape our ability to finally eradicate these resilient global diseases?